Good morning, everyone, and welcome to the Heart Failure Exchange Call. My name is Michelle, and I will be your moderator for today. Feel free to ask any questions throughout the presentation by typing it into the Q&A box on your right-hand side of your screen, or by dialing *6 to unmute your line. I will now turn the presentation over to our Senior Director, Cherie Boxberger. Cherie, the floor is yours.
Hey, everybody. Welcome to the Heart Failure Quality Exchange. As a reminder, I don't know how many of you it's your first time, but these are quarterly phone calls. The goal of these calls is to allow those of you who are working really diligently to improve the care for our heart failure patients to come together to learn if anything's new as it relates to the science. Hopefully share and identify resource needs, because we'd love to hear from you. I'm hoping that this call isn't just me. I'd love to hear from each of you as well. And please invite colleagues to join. While the majority of you are our Get With the Guidelines heart failure customers, we definitely welcome anyone who is working on heart failure process improvement. I believe at any point, and I think Michelle said this, but at any point you could hop in with a *6 and come off mute and answer questions. I would love for you to do that. Or you can type them in and keep track of them on the WebEx. Quickly, and I'll switch over to my slides, but quickly, for those of you who are Get With the Guidelines heart failure, in the last 2 weeks, you should have received from your Director of Quality a data snapshot. And we call those data days. And that means that for every quarter, even though the quarter isn't completely done, and this is for quarter 2, that we look at your data so far during the year to see how things are going, what's falling out, so on and so forth. So you should have received that report in the last 2 weeks. If any of you are Get With the Guidelines heart failure participants and have not seen that snapshot report, please type your name and hospital into the chat box, and we will make sure that you are also added to the distribution for your report. So it's an important, we think it's an important update, a way for you to see kind of mid-year what's happening. So anyway, I encourage you to do that. Our agenda for today, let's see if we move ahead. And of course my slides are not moving. Just a second. Figure this out. Try again. There we go. All righty, so this is our agenda for today. We are going to have a presentation about the Joint Commission and American Heart Association Advanced Heart Failure Certification that has been recently relaunched. We will look at current performance as it relates to our whole affiliate, and we do work, both Michelle and I work for the 6-state Southwest affiliate of the American Heart Association. Give you an update on our heart failure breakfast, because we did have 16 of those around the affiliate. We had 2 amazing webinars recently by our national volunteers, and I'm just going to give you just a snippet of those presentations, enough to just whet your appetite to go out and listen to the recordings of those. And then I do want to make sure we're all up to date. We did have an update to the patient management tool on July 11th, so want to make sure we have that. So we will get started. Pooja, I don't know if you're on the call. If you are, just *6, and we'll move to your slides. Pooja, are you on?
Okay, this is Pooja. Cherie, are you able to hear me okay?
You sound great.
Perfect. Okay, I'm glad it worked. So, hello, everyone. Good morning. As Cherie mentioned, we would like to present to you some information about a relaunch of our Advanced Heart Failure Certification Program with the Joint Commission. My name is Pooja Patel, and I work at the National Center Office of the AHA in our Quality and Health IT team, and I oversee our accreditation and certification programs for stroke centers as well as for cardiac centers. Recently, in an announcement about a little over a month ago, the American Heart Association and the Joint Commission came together, and we announced our expanded collaboration in cardiovascular certification programs. This is really, our goal is really to be building off of this success and some of the that we've created in stroke center certification with certifying primary stroke centers, comprehensive stroke centers, acute stroke ready hospitals, and most recently we launched a thrombectomy capable stroke center program that's really for the enhanced primary stroke centers out there that are very much capable of providing mechanical thrombectomies for patients with LVOs. And as a result of the success that we've had in stroke and as part of the American Heart Association's mission to be able to reach just as many patients, if not more, with chronic conditions like heart failure, we have most recently, it was July 19th actually, so this is very much hot off the press, relaunched and announced the Advanced Heart Failure Certification Program. And Cherie, if you don't mind, can you advance to the next slide, please? Thank you. So unfortunately, because this is so new and a lot of the education and materials that we have to share are in development, depending on, how many of you are engaged with the certification programs, we would definitely work with Cherie and the team to be able to distribute the requirements as well as the performance measures. Today I'm really just going to be giving all of you an overview. So like I mentioned, this certification program we did develop the requirements for in collaboration with the Joint Commission. And as we were building the program requirements to enhance the quality of care all of you provide as Get With The Guidelines heart failure hospitals, our goal and our intention was for this certification to be able to assist hospitals in helping patients manage their chronic diseases, reduce unwanted variations in care so that we can improve patient experience, improve efficiency and outcome at a potential lower cost. And so our goal is really to help hospitals with the certification program reduce length of stay, reduce readmissions, and improve their transition of care into the outpatient setting, which is a new and exciting development that we're working on as well. Our goal is to really help hospitals position their heart failure service line to effectively face some new challenges. And we've also been working with the Joint Commission for new sites that are now going through renewal as well as new applicants to enhance the survey experience that combines the unique survey approach with what the American Heart Association has developed in our consultative approach that really helps hospitals that are already participating in quality registries like Get With The Guidelines heart failure, so that it's really not, I think the traditional sense is that there's a checkbox approach for sites who are either meeting the requirements or are not meeting the requirements, and I'll speak to that in a second. But we are working on enhancing that experience overall because we want to help hospitals in their journey once they become enrolled in the Get With The Guidelines heart failure registry. The certification helps sites receive additional recognition for their quality programs, and there's some special initiatives like opportunity to participate in research, have presentations, as well as be able to work with payers to really help maximize reimbursements provided back to the facilities for your heart failure programs. And it really does promote a culture of excellence to boost retention and recruitment of talent for your heart failure service line, both at the clinical level as well as the ancillary level with looking at administrators who are very much attracted to helping build heart failure service lines with the rising cost of healthcare, particularly in heart failure. And then because we just announced this program and the relaunch of this program with the Joint Commission, although all of these existing certified sites are already participating in Get With The Guidelines heart failure, which is amazing, we will not be mandating that sites be signed up and actively participating, meaning submitting data in the registry. That will be mandated as of July 1 of 2019. However, applications have officially opened as of the date that we announced it, which was just a couple of weeks ago. And I think I have one more slide to present to the group. Yes, thank you. So just a quick overview that there are core requirements or standards that the Joint Commission calls, and really those standards are looking at disease management as a whole, patient safety and quality as a whole, as well as information technology and how sites are validating the integrity of the data that they're collecting and showing to the reviewers during the review process. And then there's specific advanced disease-specific requirements that really are built off of the ACC-AHA Heart Failure Clinical Practice Guidelines, and those were developed with our authors, researchers, and some key volunteers from our Get With The Guidelines Heart Failure National Committees. there have previously been and continues to be the same performance measures that we will be requiring. And I inserted a link to those if you do share the slides, you were able to share, the performance measures if anyone is interested in looking at those. But there are 6 standardized performance measures that are really both process and performance oriented for the inpatient program. And there are optional 7 measures for the outpatient programs. And as we increase the number of participants, the number of sites, we really are planning to get together some leaders that are from certified facilities to help us do some testing with the outpatient program measures as we're building the post-acute care program and really looking at ways to validate additional measures into the as part of your care transition. And then steps, so lastly, in order to achieve certification, like I mentioned, we don't have the standards available just yet on the public domain to share. However, if you do reach out to us, and I have our email address listed here, we're more than happy to share with you the standards, additional participation requirements, as well as the performance measures for which hospitals will be expected to comply and meet the eligibility by the time you submit your application. And we do have AHA teams available to help you work through that before you submit your applications. If you have any questions, please don't hesitate to reach out to us. We're more than happy to help you. We can help you do a gap assessment or a self-assessment just to determine your eligibility and your state of readiness, as well as to help you put a plan in place in order to be eligible and ready to pursue the certification itself. Then lastly, once you are ready, we will be submitting your application directly to the Joint Commission. But all the steps in advance of you preparing your application for the Joint Commission, you could work on directly with the AHA team. At this point, I think that's about all I have because this is, very much hot off the press. So, Cherie, I hope this was helpful, and I'm not sure if this is an appropriate time to take questions, but if it is, I'm more than happy to do so.
Oh, yes, we'd love to be able, if any of you have questions, either *6 and just come off mute and just ask Pooja directly, or type them in. And Michelle, you can let us know if there's any typed in questions.
Yes, Pooja, we have a question from Virginia. What is the difference between this one and the ACC accreditation?
Yes, so that's a great question. I think many of you have been familiar or may have been following, some of the changes that's been happening with the trade organizations and public health organizations like the American Heart Association and the ACC. But ACC's requirements are also, so I will first preface by saying that the American Heart Association really can't speak to ACC's program as far as, the standards and the requirements. Both of our program standards have been built off of our ACC AHA heart failure clinical practice guidelines. I know there are specific and unique data elements that ACC requires, as well as different registries and data sources that the ACC requires. So if you're not, or if you are already using Get with the Guidelines heart failure, the good news with the program that we've launched with the Joint Commission is that your data collection and submission process will really be seamless because our tool allows sites to be able to submit and report data directly to the Joint Commission through your active participation in Get with the Guidelines. ACC has their own tool and their own program, and so that's really geared for sites that are not already involved with the American Heart Association and, in our quality programs like Get with the Guidelines. And so there might be unique differences. I know our local teams have been doing crosswalks. If you are interested in doing side-by-sides, we can definitely get you connected with the local teams. But from a national level and a national perspective, we've aligned with the Joint Commission because our goal was to really provide less requirements for duplicate data entry, but really to be able to seamlessly help hospitals in their journey, their quality improvement journey, especially for the 500 plus sites that we already have engaged and Get with the Guidelines that we're really looking to help improve their quality in an effort to become certified. So I'm not sure if I directly answered that question, but I hope that context in the background is helpful.
Thank you, Pooja. Other questions from the chat or just *6 and pipe up?
One more question. Is it still required to have a VAD program, VAD?
No, not for the Get with the Guidelines. So that is a good question. No, sites are not required to have an active VAD program. This is very specific just to whatever clinical setting that you're focusing on for heart failure. As long as there's quality and integrity behind the process and how that was built, you would be eligible. And the other update, which I failed to mention earlier, is that when we had originally launched the certification with the Joint Commission a few years ago now, about 3 years ago, sites were required to have an award of bronze or higher with your Get With the Guidelines heart failure program. We have since updated that because our recognition and award structure has evolved since then, that sites that are actively participating in Get With the Guidelines, regardless of your award status, you are eligible to apply as long as you meet the requirements.
Anything else, Michelle, on there?
That was the last question on my end. Remember to star 6 if you want to verbally ask a question.
And while we're waiting just a second, okay, go ahead.
Oh, sorry, Sherry. I was just going to share, while we're waiting, our teams, both the AHA and the Joint Commission teams, are currently in the process of developing additional educational materials as well as some webinars so that we can share more information with you as soon as it becomes available.
Thanks, Pooja. I think that for me as a director, the thing I'm most excited about for those of us who work with you in the hospital is that we're going to be able to provide a little closer support as you're considering being certified, as you're going through the process to prepare. Where in the past where we might, even with our previous Joint Commission relationship, we might have said, to contact the Joint Commission, which you still can, of course, but it's having that on-the-ground director who can actually kind of hold your hand, so to speak, but work through it with you. So you really get that consultative benefit of having a QSI director from the AHA side by side. So this really isn't just about checking the box and saying, yay, we're certified, but about that process improvement and as the guidelines change, staying up, because this population is just continuing to grow and expand, and we need to be prepared to provide guideline-directed medical therapies for them. So any other questions, Michelle, or by voice? All right, don't forget accreditation at heart.org or that silly word accreditation, it's always so hard to spell. Don't hesitate to just pop a note into the box that you'd like more information and along with your contact info, and we'll get it sent out to you. We're really in the early stages, so this is a great time for your institutions to consider it. So thanks so much, Pooja.
Thank you, Sherry. Thank you all.
All right. Pretty exciting stuff. All right, well, let's hop in and let's look at the performance. As I mentioned, you should have received your snapshot of your personal organization a couple of weeks ago. I realize that's not Q2 complete, but at least gives you an idea for Q1 and Q2 how you're performing. When we look across the 6 states, we have 82 hospitals that are utilizing our registry, but unfortunately, right now only 56 have data in the system. So we're working diligently. If there are some of you on the phone who haven't been able to put in 2018 data, or you lost an abstractor and you're behind, anything along those lines, reach out to your director, or you can even just ask for help today through the chat box, and we are glad to come out and talk with you. There are opportunities for you to create uploader files directly from your out of your electronic health record to perhaps bring up part of your data points. We can help you get up to date or to get a new person trained or whatever is necessary to be able to put your data in there. So as we look across our hospitals in the Southwest affiliate, and I'll just be paying really attention to the silver box, and we'll try to make this a little bigger next time. Sorry, it looks a little small here on the screen, but when you look at the silver box, that's aggregate, and if you recall, we need to have 85% in the achievement level, the top tier of quality measures at 85%. So 23 of our facilities are on track for the achievement award. So that's either gold or silver, depending how long you've been on track. The plus awards, which is those next tier of quality measures, and I hate to even call them second tier because several of them are class 1 recommendations, but we did choose to start with the top 4, and then you have to have 4 of the quality measures. So we have 32 facilities who are on track for that. And then, of course, the goal for target heart failure. And target heart failure, the goal is really around the transition of care, making sure that patients are getting adequate education and are being transitioned post-discharge appropriately. So that's kind of us at a snippet. Probably more importantly is to look at the actual individual measures. And so, interestingly, and I thought this was fascinating to me, and I'd be interested if anybody wants to pipe in, almost in every measure, the first quarter performance was inferior to the second quarter performance. So that's kind of interesting. If you look there at ACE, ARB, and ARNI, with 85% in Q2 across our hospitals that have data. So as a whole, our hospitals are not meeting the requirement at 77%. We need to be at 85%. So again, the options are an ACE, ARB, or an ARNI, and they would have to have a contraindication to all three. What I'm seeing as I look through your records is that you may be answering yes to contraindication, but you're not indicating what that contraindication was. Evidence-based data blockers, writing about the same point. Again, really important, a Class 1 recommendation. Have to identify those docs that are prescribing the other beta blockers other than the 3 evidence-based beta blockers. Measuring LV function has historically been excellent, and then the very difficult post-discharge appointment for heart failure patients. And I just want to reiterate what this measure is. I think there's a wide variety of things happening out there, and we have gone to our national committee to ask for some specificity. We know in communities that have don't have as many cardiologists or don't have a collaboration, this is very difficult because the goal is to have the actual appointment date and time. And remember, if you just put a date in but you don't put the time in, it will it drops from the measure. It's not in compliance. So you have to have a date and a time in the medical record at the time of discharge. And I'm not unaware how difficult that is. I know some of you are trying to meet that with clinic visits with advanced practice staff, either APNs or PAs or other settings. Some are trying to do with phone calls. At this point, unless that phone call is indicative of a actual visit, it does not meet the requirements. I have submitted that question to our national committee. So I'm interested, how are some of you dealing with this post-discharge appointment? If anyone is willing to share how you got this under control, because I know there's some hospitals that are on the phone who have 95, 98% compliance in this measure. Would you be willing to hop on and tell us how you're dealing with it? Just *6 and tell us what you're doing. Anyone work with their physician offices or have access to appointing or that type of thing? And feel free to type in these solutions too, but we need to figure out as a country how to make sure. I'm dealing with my father-in-law right now who's living with me, age 87, and was hospitalized. The post-discharge processes are very complicated, and if there is not an appointment set, I can tell you we have called so many people trying to find out how we're going to get into the post-discharge appointment. Did I hear somebody come off mute to contribute to this discussion?
Hi, this is Allison from Wyoming Medical Center.
Hi, Allison.
And we have social workers that we call care managers. They help us make those appointments before the patient goes home, and it gets added to the discharge packet.
Fabulous. And is it both perhaps their primary care physician and others? How do you handle that? Sometimes they go back to their own, or
well, we also have a cardiac group who has started a heart failure clinic, and those mid-levels, NPs and PAs, they also will make sure that the patient, if they've had heart failure, get put into, and if they've got a consult from them, that's another big thing. will get put into their heart failure clinic within 7 days, and they follow them for 4 weeks. They'll see them one week, they'll call them the next week, they'll see them the next week. And so that's really, I mean, but we started with the ACC Navigator program, and so that was recommendations. And so.
Absolutely. So that's how you got started with that when you were working with that. That's good.
Uh-huh.
I mean, this is probably one of the more difficult ones. How do you find your are your heart failure patients coded pretty easily? How do you find your list, or how do they get into this? Is it through order sets? How do you find your list of folks who need to be
we have
followed?
The Cerner, we have the Cerner system, and it makes a report for us that anybody that has a BNP gets on a list. And so we write those people down if it's 125 or higher. And we do a lot of chart reading. And I have a teammate, and we work on it together. And then we also get notification by Cerner if somebody gets Lasix in the ER and is admitted. So we're able to catch people better that way. But then we're not a terribly big hospital, so then we run through, and any of the diagnoses that we've gotten used to looking for, we scan those charts quick too, so we don't miss anybody.
Yeah.
And
I'm hearing this from lots of hospitals. It really takes that extra legwork to find those patients, sounds like.
Yes. We watch people sometimes until they're totally gone, till I'm discharged from the hospital.
Yeah, just seeing how they're coming up. Are they having Lasix? Are they having some of those things? What are their lab results? Good. Thank you so much for sharing, Allison. Very good. Anyone have questions for Allison, or have an alternative way that you're handling this? Or I'm interested in what your roadblocks are. I know one of you told me that the physician that you referred, you were trying to make the appointment, and the physician said they would not make some appointment until they evaluated them. And, of course, that wasn't going to meet our requirements. So I'm interested in roadblocks also. Any comments to that? Just *6 or type them in.
Yes, Cherie. So someone asked, how do you get your physicians to agree to this?
Allison, are your physicians employed physicians, or how did you work that so that they would get them in the time that they need to?
Well, we have.
Or you have to start. Oh, there you are.
Yeah, we have 3 different physician groups, pretty much. The cardiology group, a hospital group, hospitalist group, which is employed by the hospital, and so things in their contract can apply to what we're doing. And then we have a residence group, and we have 2 cardiologists that are our physician champions, and they educate everybody else. And so just having those physician champions to back us up is really good. Plus also we have a physician in our administration who she wants all of this to be on, and she watches everything that we do. And so that is also a really good way to get the things going that need to be going for our patients.
Oh, Allison, I can't. The physician champion, for those of you on the call, if you do not have someone that you can really know is your physician champion and has your back, you need to find that person. And I wouldn't be deterred by their age or it's great if you have a super influential, but a passion for these heart failure patients and somebody who will speak physician to physician to the need for these patients to have a proper transition. Because we are readmitting these people almost the day after they go home if we haven't made a plan for them and that they know what to do. So here, Allison, as it relates to the physician champion. Other questions or comments, because that's the purpose of this. I'm seeing people all over the country struggling with this measure because the physicians are pushing back.
Yes, Allison, what is the bed capacity of your hospital?
Right around 200. So we're small. When we were in the Navigator program, they called us the Frontier. A little.
Well, we have that frontier. You know, we talk about rural, and then there's that next category.
Yeah.
Frontier. Before we leave post-discharge, anybody, any other comments or suggestions for your colleagues? And we are recording this, and so that people can listen to this. So we love real-world examples of how you made this happen. All righty. Now, this is a tiny slide, and it'll be included when we send out the results, but it kind of gives you an idea. This is the plus measures, and I just want to point out a couple of things because, for instance, aldosterone antagonist is a Class 1 recommendation and something that across the country we're still only performing in the 30 or 40% category. And so, and you can see here for our affiliate, although it was 38 and then 52 in Q2, but 40% is the aggregate number for the use of aldosterone antagonists at discharge. Majority of these others, obviously the follow-up in 7 days, which ties very closely, and I want to make sure we're clear, the 7-day thing confuses some of the abstractors, because you don't have 7 days to put the appointment on the chart. It has to be on the chart when they're discharged, and then they need to be seen. That appointment should be in 7 days. So you can see you can meet one and not the other, so that's why they stand alone. ICD consulting or ICD placed or prescribed, if you have a EP practice, an electrophysiology practice, this is actually one of the things in heart failure that has some revenue potential. You can provide guideline-directed medical therapy, and it can be beneficial to the bottom line through the ICD process or through electrophysiology. So that's something where you can have a separate champion to make sure, because really all the patients who are eligible, this should be 100%. Because it doesn't mean they had an ICD placed, it means that they were counseled on the potential or it was prescribed for evaluation. So something that we ought to look at. And what are the pushbacks, real quick, well, I'm going to jump ahead here, because when we look at these things, especially when you look at aldosterone antagonists, where you only, the number needed to treat to get a mortality difference is only 6, you have a relative risk reduction in mortality of 30%, a 35% relative risk reduction in heart failure hospitalizations. What are the pushbacks on this particular measure, why you feel this isn't being done at discharge? Anyone? Star 6, or type it in. And I just encourage you, and I think I did this on the last one, so I apologize, but this is important. A couple of our urban core hospitals here in Houston are working on ACE, ARB, ARNI, and aldosterone antagonists. They selected 2 measures to look at because they have such an impact on readmission. So I encourage you to look at the literature related to this. For those of you who are Get With the Guidelines Heart Failure, you can pull up within the measures the rationale for and the actual studies that were a part of this that made this a Class 1 recommendation, and get that physician champion to help you on this so you can start following this. And you are able to use your Get With the Guidelines Heart Failure to look at this by discharging physician. So you can even get to your hospitalist groups, you can get to those docs that are doing this, and find out what the roadblocks are of not of this treatment. So, any other comments?
Yeah, Virginia has a comment. She says aldosterone is not often prescribed because CRF. However, many physicians choose just not to document this as a reason.
See, that is possible that we're getting that group of folks again in there where it is contraindicated, but it's not documented. So I'm fully aware, and maybe that's the whole deal across the country, is that we're missing that documentation. But it seems important to look at that. So thanks for that feedback. That's great. Virginia, I think it's who you said gave that. Any other comments, aldosterone antagonist? All right, well, we're moving along. Heart failure honor roll. That's where we're looking at these, the referral to a heart failure disease management programs, the follow-up visits, and then it's combining. So it's really bringing those really top 5 elements together into what we call target heart failure, really giving you the recognition, because these are difficult to make with the follow-up in the 7 days and so forth. So, all right, and I'm going to show you this probably every time because it's just important to note that when it comes to heart failure with reduced ejection fraction, we have a lot of scientifically founded treatments. That being said, I don't know how many of you, and if you were on these, don't hang up because I'm just going to spend a second on these, but I want to make sure that everyone is aware that this webinar occurred. It occurred on July 10th, and it's available online for you to watch again. And it was a 3-part program related to heart failure with preserved ejection fraction. And these fine national volunteers presented. A few highlights from the program, again, here's who are the presenters, is that they really talked a little bit about this changing epidemiology of heart failure. And you can see here from 2005 how we've had, because we have treatments, how these have kind of crossed over, and we're seeing many more of the preserved ejection fraction heart failures. And of course, there's similar survival just because you have you don't have that one ailment where you still have the same challenge as it relates to mortality. In the webinar, he talked a little bit about the different cardiac mechanisms. Why does this even happen? What's going on? How some of those are evaluated? Because it's really an interesting type of heart failure. And I also talked about the other organ systems and how they might impact a preserved ejection fraction heart failure. And some ideas of how to look for other causes. So I am just picking a few slides out of here to whet your appetite for going in, but excellent presentation as it related to this and kind of giving us an idea of the things that go along that might need to be addressed when you're talking about these heart failure patients. You can't just look at them in an isolated fashion. The second part of the webinar was from Dr. Deswal from here in Houston. And this was very interesting because, of course, she talked about what the evidence-based or the guideline-directed medical therapies are for reduced ejection fraction heart failure, and then what the class 1 or the evidence-based recommendations are for HFpEF. And you can see that this is an area where we're still working on that. And another important reason to be working with a registry. She talked about the recent focused update from 2017 and went through the various you can see the level of evidence for these is always going to be low because we simply don't have it. So the use of beta blockers, ACE and ARBs, in patients that have hypertension and they do have this type of heart failure, that's a class of recommendation 2A. That the same patients that they might be considered for aldosterone antagonists. The use of ARBs might be considered to decrease hospitalizations. Again, we're not talking about any level of A evidence. We do have a few things that she went over that there's no benefit on, including the use of nitrates, et cetera, as well as looking at nutritional supplements, although we did hear later that some of the patients who are having difficulty maintaining weight, they're using nutritional supplements for a different reason to maintain endurance and that kind of thing, but no benefit to the actual heart failure. And then diuretics, obviously, again, with this category, still only a Class C recommendation. Always important, the Class 1 things here are related to hypertension and really being super vigilant with these patients as it relates to treating hypertension. A Class 1 recommendation, again, not level of evidence A, but B there, And, of course, we're looking at trying to keep systolic less than 130, sorry. And then some of the comorbidities were addressed in this presentation as well. And I'll just go through these. So I encourage you to get on and listen to this webinar. The third part, well, here's the summary of treatments. We're looking at the volume overload. We're looking at hypertension. We have seen that if they're at high risk for heart failure hospitalizations, you might consider ARBs or aldosterone antagonists. Obviously, again, to our comment, if there's no contraindications, and then, of course, you have to look at the various comorbidities. The third part of the webinar, Dr. Nancy Albert talking about non-medication or pharmacological care, so really looking at exercise, weight management, that kind of thing, making sure that before discharge and at each post-discharge visit to look at those comorbid conditions. You certainly can't look at heart failure in isolation. To really address, and this is the difficult one is the next two, to address the heart failure cause barriers in care and limitations in support, and that is so complicated. I think I had mentioned those are some of the things we've discussed in our heart failure breakfast, is what are the roadblocks to patients getting the care. Really ensuring heart failure education, including self-care, emergency plans, and she really emphasized, and I encourage you to listen to discuss how, not just what, because we really go down this list, is red, yellow, green, so on and so forth, but we don't discuss the how as much. And then she talks about palliative care, and our next presentation actually is an entire hour on palliative. So this gives you a little bit of an idea what the third part of this program was. Very interesting, related to the benefit of weight loss, exercise, and other non-pharmacological things. The next webinar, now this is a separate webinar that was on July 18th with Dr. Goldberg. Again, this is available to listen and watch online. We'll include the links to those. There's no cost for this. For heart failure palliative care, very excellent program. And so really, he emphasized this, improved survival is really making it where we have to be talking about palliative and hospice care, making the distinction early on, getting patients involved in palliative care. And so he basically talked about that with the new devices, there's new challenge. We've got these ICDs. Are you going to deactivate them? We have VADs. Maybe they aren't feeling well. Maybe they're super sick, but they really can't die because we have that device in there. So gave some very good information on that. Again, emphasized different the different classifications and where we could start to encourage patients to consider some of the palliative care opportunities. And I learned a lot in this. Palliative care, I think we get confused, and even patients get confused and are always making palliative care and hospice interchangeable, and certainly that is not correct. But what we're really looking is at improving the quality of life of patients and their families facing the problem associated with life-threatening illnesses. And so what are we focusing on? Prevention and relief of suffering by early identification, and really looking at everything from pain to physical, psychosocial, and spiritual. So very good distinction. And then provided this diagram from JAMA of showing that palliative care is a much broader category. And he gave many resources that you can look at. This is an excellent comparison to just give you some insight into the palliative world compared to hospice. And importantly, appropriate at any time during the serious illness, independent of goals or prognosis. Really, he emphasized that we are not getting this going early enough. The palliative care is across the community, everywhere from in the hospital to the physician's office to community, that it's very complicated. And then I thought what was so interesting is that what he found out is that patients actually asked, and he compared palliative care in non-small cell lung cancer. And what they basically found is that patients who had early palliative care survived longer and had improved quality of life. And I think this is just a shift in our mindset related to palliative care that I was surprised to see. And then, of course, you're seeing there the standard care versus the early palliative. So I encourage you to go and look at this. It's a very complicated diagnosis, but we need to much earlier be working with these patients and their families to discuss what's going on and what they might want to change in their care and treatment plan. So I'll flip on through these. Here's important. Inpatient palliative care consults improved at 3 months the quality of life, the symptom burden, and depression. And we know how much depression is a part of heart failure. So I'll go on through these, sorry, but you can see how, oh, this is interesting. So even if there were no improvements in symptoms after hospitalization, 68% of heart failure patients said they were interested in receiving palliative care once they were presented with what that opportunity was. So encourage you to go out and see this. I'll include the handouts from it. And you can see it's a very thorough 1-hour presentation on palliative care in the heart failure patient. Any questions or comments as it relates to what you might be doing at your facilities in the world of palliative care with your heart failure patients? I'd love to hear. Just *6 or feel free to type something in, or if there's any comments or questions, Michelle. All right, well, I'll send those links so that you can take advantage. For those of you who have the Target Heart Failure app on your phone, we talked about that last time, you can listen to these presentations through your phone, iPad, or computer where you're using the Target HF app, and we'll include instructions on how you can take advantage of these webinars. All righty, a few important dates. We have firmed up, we've made some determinations of when we want each quarter's data to be complete across the continuum of Get With the Guidelines. So these dates are 60 days after the end of the quarter in question. If we can meet these dates, we'll definitely be in a better place when we get to the recognition in the early part of 2019. So on August 29th, we're encouraging you to have your Q2 data completed, the discharges in Q2, and obviously Q1 as well. You need to have all 4 quarters to be eligible for recognition. I wanted to point out that the Heart Failure Society of America, I have a typo there, sorry, September 15th to the 18th, there aren't a lot of conferences that are heart failure focused, and this is an excellent conference, a lot of hands-on type of information. So if you happen to be still allowed to pursue some education, this is an excellent opportunity, September 15th through 18th. It's over a weekend. You don't have to take a lot of days off of work. I think it's only 1 work day, and you could be able to really benefit that. It was in Texas last year, and it was excellent. I want to point out to you a conference that you may not be aware of. It's called QCOR. This is American Heart Association conference. We've had it for years, but we are going to be having a registry or Get With the Guideline track as a part of QCOR. This is a research-focused conference, but that is kind of what we do out of our registries. We look at process improvement. So QCOR is another opportunity, like scientific sessions, for you to submit abstracts for presentations or posters. I'll attach the link related to this. QCOR is going to be April 5th and 6th. It's only, again, 1 work day. We're shortening many of our national conferences to reduce the travel requirements on our health professionals. so it's going to be April 5th and 6th. And if you have something you're working on in heart failure, this is a great opportunity by the end of October to submit an abstract. Our next call like this will be October 30th. There's your Q3 data. Very important is you need to have all of your 2018 data in by March 1st, and that will give us 28 days to study, look at it, see if there's any contraindications that are missing, send you back perhaps to double check the record, and really clean that up so you can be recognized. There's the Q-Core conference, which is in Washington, D.C., and that is where we are going to be giving the heart failure recognition. There's going to be an event at Q-Core for all of those who are recognized as gold and silver, most likely. Those will be the categories. So you might put that on your calendar. And then, of course, in May, the recognition awards are approved and distributed. Any questions as it relates to these data deadlines? And this doesn't mean that if you don't have it done, you can't go back. We're not going to close off data entry, but for our reporting to work well and for us to be ready for recognition season, this is the best way to go. Any questions? Anything written in, Michelle?
Nothing on the chat.
Okay, I'm going to super quick go through. I need to change presentations. Here we go. Just want to make sure. Go ahead.
Yes, just wanted to add on scientific sessions, November 10th through the 12th. It's a new 3-day format. Feel free to join in Chicago, Illinois.
And that's correct. And that is where we previously had our big recognition event for heart failure. And so this is a transition this year. There'll still be some recognition there on posters and so forth, but the primary recognition for heart failure performance will be at Q-Core. So that's an important differentiation. We would love for you to attend both, but know sometimes you have to make those decisions. And it is going to be nice that scientific session has been abbreviated a bit to take less time. That means it will cost less. Want to make sure you're aware that July 11th, if you haven't been in your patient management tool, it was changed on July 11th, and we retired the ICD-9 fields. The historic, we're way beyond those now. Added new sleep disordered breathing fields. There were some lab field additions added. For example, BMP can now go all the way up, even though those are not normal. We do sometimes have some crazy out-of-line BMPs, and previously you would be locked down and couldn't close that record. That's been fixed. Updated the medications at discharge, added ARNI to the follow-up. And the measures that were changed back in 2017 are now up to date. Here is where you'll see that we added the sleep disordered breathing to medical history because our guidelines now discuss that. Here's the examples, the things that were changed in the labs. We added ferritin to the labs. There's that BMP. It's been changed so it can go up to 99,999. We updated the range on potassium as well. Here's your the label updated to bold, so that means it's required. The reasons for not switching to ARNI at discharge. So this may require some education amongst your physicians that that is not being documented. So here we added 5 ARNI elements to the 30-day follow-up. The standard things: was it prescribed? What have they done since discharge? Have they missed any doses? If you are not using the 30-day follow-up form in your clinics or your other outpatient settings, I encourage you to do that. We can help you get those clinicians up to date so that they can use the 30-day follow-up form. It's a great way to study what's happening with your patients and those who are being readmitted. Here's your new discharge medications that were added. And dosages and changes, things that are related to what's available in the market. Telehealth been added as the first follow-up. Lots more as it relates to telehealth, so we have added that as an option. Also, referral to sleep study has been added. And then we added 3 new reporting measures. So as you're looking at different things related to medical history, blood pressure control at discharge, or aldosterone receptor antagonist for preserved ejection fraction, you can now report on those. So anyway, we'll attach this. You probably have seen this. This should have come to you through email. If you have not seen this, please let Michelle know that in the chat box, and we will make sure that IQVIA, formerly Quintiles, has you on their contact list. Don't forget, Get Guidelines to Go. It's an app available on your phone. When you pull it down, if it's pink like it shows on Altaplace and Rehab, that means there's new guidelines that we've put out. So I really encourage, lots of our docs are enjoying using the AHA Guidelines to Go app. Just as a reminder, our Heart Failure Breakfast Series continues this fall. We have dates and times that will be in your post-meeting report so that you can pick and attend one of those. And there is my contact information. I think we have, 3 minutes. So any questions? This can be on anything related to heart failure, whether it's the patient management tool or heart failure in general, or AHA questions, things you've thought up about the certification or the accreditation, anything.
Cherie, we do have a question about the plus measure. The ICD counseling, would an external defibrillator count for this metric?
Do you remember, Michelle? I don't have those. I will answer that and look at the coding instructions. Make that note, Michelle. I don't know if that's one you've answered.
We will look into it and we'll answer it by email.
Yeah. Good question. And any questions you have, we want to make sure that we're putting them out to the whole group, even if I can't answer them on the phone without referring to the coding instructions. The coding instructions have also been updated effective July 11th. So if you're someone who prints your coding instructions, you need to print a new set. The things that are new will be highlighted in there. Other questions? All right. Well, I am excited about the progress we're making in the treatment of heart failure patients. You guys are all working so hard. This is so important because all of us, I'm a baby boomer, I'm going to be heading into this category where more and more patients, because we're doing such a good job on saving us from our STEMIs and our strokes, there are going to be more of us suffering from heart failure. And so this is going to be a very important element, a very important treatment area that we need to focus on. So, Michelle, any other final comments you have?
Final comments. So all the slides and the recording will be provided to you within a week of this call. So just be expecting that in your inbox.
I appreciate all of you. And Allison, thank you for sharing, as well as Virginia and others of you who typed in. We appreciate you and wish you have a great week. Thanks so much.